Hello, 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 ladies and gentlemen. All right, so we have talked about the musculoskeletal system, and then we talked about connective tissue disorders because that was kind of associated. Now we are talking about allergic disorders. Sometimes allergic disorders also have to do with autoimmune disorders. So again, still a little bit of a tie-in, but also a little bit of a stretch. So the immune system will provide defense against microorganisms through first-line barriers to infection and the inflammatory and immune response. Immune disorders may be due to either a deficiency or to overactivity and may involve one or more components of the immune system. So deficiency can result in disease processes. Overactivation results in reactions that will include anaphylaxis, ladies and gentlemen, and immune disorders. So, when the immune response is initiated inappropriately or when it overreacts, autoimmunity and hypersensitivity reactions can occur. Autoimmunity is when the body initiates an immune response against the self. Antibodies are formed that will respond to normal healthy cells and tissue. A hypersensitivity reaction is when the immune response is overreactive to a foreign antigen. An antigen is a foreign protein that will stimulate an immune response in a susceptible individual. Hypersensitivity reactions can be damaging to the body, may cause discomfort, and may also be fatal, as in anaphylaxis. There are several categories of hypersensitivity reactions. They can be divided into 5 types: type 1, type 2, type 3, type 4, and type 5. Focus here will be on type 1 and type 4. Hypersensitivity reactions and autoimmunity overlap. Many autoimmune diseases have hypersensitivity as part of their pathogenesis. So, for example, Graves' disease is an autoimmune disorder that will result in a type 5 hypersensitivity reaction. Systemic lupus erythematosus, SLE, which we discussed in connective tissue, is a result of a type 3 hypersensitivity reaction. And then Goodpasture syndrome and is an example of a type 2 hypersensitivity reaction. Most, but not all, hypersensitivity reactions are manifested in autoimmune disorders. One that does not manifest as autoimmune is the type 1 hypersensitivity reaction. This is a typical allergic reaction. Type 1 hypersensitivity reaction is a rapid or immediate allergic reaction. There can be a local, we call this a topic reaction, or it can be a systemic reaction. The most common is allergic rhinitis or hay fever. We call this a local reaction. The most severe form is anaphylaxis, and that is a systemic reaction. A genetic predisposition will exist for the development of allergic diseases. If both parents have allergies, then there is an 80% chance that the child will also have an allergy. So approximately 20% of the population is atopic, which means having an inherited tendency to become sensitive to environmental allergens. And these are the substances that will cause an allergic response. So allergic rhinitis can be perennial or seasonal. Perennial rhinitis is caused by dust, molds, and animal dander. Seasonal rhinitis is caused by pollens from trees, some weeds, some types of growths. An accurate incidence of anaphylaxis is not known because of the differentiation between a full-blown anaphylactic response and then a milder case. So there are up to 1,500 fatal cases of anaphylaxis annually. And this seems to be increasing, especially in cases of children being allergic to certain foods. So, ladies and gentlemen, listen up, and then listen up one more time. The primary mediator of a type 1 hypersensitivity reaction is immunoglobulin E, the IgE. So the first time a patient is exposed to an allergen, IgE will be produced. These IgE antibodies will attach to a mast cell. The next time a patient is exposed to that specific allergen, it will bind to the IgE antibodies that are attached to the mast cells. This will cause the mast cell to degranulate, releasing histamine and other chemicals such as leukotrienes and prostaglandins that will cause smooth muscle contraction, vasodilation, increased vascular permeability, bronchoconstriction, and then edema. Ladies and gentlemen, please take note. So this will result in the symptoms associated with the allergy. Anaphylaxis is the most severe form of a type 1 hypersensitivity reaction that will exhibit the extremes of the symptoms. So anaphylaxis can occur when mediators are released systemically. So clinical manifestations, there are various clinical manifestations and they may be local or systemic. Clinical manifestations of allergic rhinitis will include nasal drainage, sneezing, and pruritus of the upper airways. The patient may complain of a headache or sinus pressure. The patient may have itchy, watery eyes. So in anaphylaxis, which is a systemic response, there is an immediate response to an allergen. The patient may complain of dyspnea. This is what we call difficulty breathing, and then shortness of breath. Ladies and gentlemen, please take note. Please take note. Audible wheezes and or crackles will be present. You will be able to hear this. There may be a skin reaction such as a rash. Your patient may experience nausea, vomiting, diarrhea. They may complain of anxiety and often state that they feel flushed, that they feel very hot. Angioedema. Angioedema is swelling just below the surface of the skin, typically around the mouth and the eyes, and this may also be present. In a severe, extreme allergic reaction, there will be a severe and rapid onset of these symptoms. Ladies and gentlemen, listen up, and then listen up one more time. Clinical manifestations will include bronchospasm and extreme dyspnea and shortness of breath and that wheeze. The patient may have hoarseness, they may have stridor. Stridor is a very high-pitched crowing sound, which will indicate narrowing of the airways. So severe or untreated reactions are going to result in anaphylactic shock with hypotension and tachycardia due to the vasodilation and then the capillary leak. So, medical management. Diagnostics will include a WBC count and a differential. The test will reveal an increase in eosinophils, which will indicate the presence of an allergic response. Skin testing can be performed to determine the specific antigen. Various allergies are introduced via a scratch test to determine which will produce a positive reaction that will indicate an allergy. A localized reaction, or what we call a wheel, will indicate a positive result within 15 to 20 minutes. So glucocorticoids and antihistamines are discontinued 5 days prior to the testing. And then doctor may also ask that NSAIDs will also be discontinued prior to testing. So ladies and gentlemen, please listen up, and then listen up one more time. Treatment will depend on the severity of the reaction. So allergy management will include the identification, the treatment, and then the prevention of the allergic response. Avoidance therapy can be successful when the allergies have been identified. So if a reaction does occur, but it is mild, then removing the offending agent may be the only necessary action. So if symptoms persist, antihistamines and decongestants can be utilized. So diphenhydramine hydrochloride, otherwise known as Benadryl. That is an antihistamine, and that will decrease edema and constriction of the smooth muscle and the respiratory tract and in the blood vessels. So steroids may be indicated to decrease the inflammatory response and decrease mast cell degranulation. Beta agonist bronchodilators may aid in easing respiratory distress by causing respiratory smooth muscle relaxation. And then in severe cases of anaphylaxis, prompt recognition and treatment are necessary to avoid a potentially fatal result. So, ladies and gentlemen, listen up, and then listen up one more time. The clinical manifestations associated with a type 1 hypersensitivity reaction are caused by the release of histamine and other chemical mediators from mast cells upon exposure to this antigen. So typical results from a histamine release will include bronchoconstriction, increased capillary permeability. Runny nose, itching, red eyes, and a rash are very common, but in extreme cases, the patient will complain of shortness of breath and dyspnea. There may be wheezes on auscultation. Please take note. So, a nursing diagnosis for a type 1 hypersensitivity reaction is risk for complications of allergic reaction, wheals, itching, lightheadedness, hypotension, wheezing, dyspnea, chest tightness, decreased level of consciousness, respiratory distress, and shock. So some nursing interventions for a type 1 hypersensitivity reaction. We are nurses and we are going to assess. We are going to look at this monitoring respiratory rate, the depth, and the lung sounds, pulse ox, arterial blood gases. Because of bronchoconstriction produced by the histamine release, the respiratory rate may be increased, and wheezing, dyspnea, and chest tightness, and throat or palate tightness may be present. So because of decreased oxygenation, the SpO2 is decreased, and the ABGs will demonstrate hypoxemia. We can look at the blood pressure and the pulse. If anaphylaxis is occurring, hypotension may be present because of vasodilation and capillary leak. Capillary leak is the leakage of plasma from the blood vessel into the body cavities and muscles. Tachycardia is present as a compensatory response to the hypotension. Irregular and increased pulse and decreased blood pressure are also due to leukotriene release, which will constrict the airway and the coronary vessels. Ladies and gentlemen, listen up, and then listen up one more time. A general systems assessment will be done. Initial symptoms caused by the histamine release may be the rash and the itching, followed by the watery red eyes, the runny nose, and then the sneezing. Angioedema may also be present. The patient may complain of feeling faint. They may feel diaphoretic. Diarrhea, stomach cramps, and abdominal pain may be present because of increased acid production due to the histamine release. The patient may be restless and they may appear confused. They may also experience signs of shock, such as cold, clammy skin. Ladies and gentlemen, please take note. Listen up, and then listen up one more time. Some nursing actions would be to discontinue the offending agent as soon as possible. For example, if the offending agent is in an IV infusion, we are going to stop the IV medication, we are going to change the IV tubing, and we are going to hang normal saline. The medication causing the allergic reaction needs to be stopped to prevent any further reaction. The tubing has to be changed to prevent any further medication being infused. We are going to administer oxygen as ordered via a 100% non-rebreather. The vasodilation, capillary leak, and other shock responses are interfering with oxygenation and tissue perfusion. So starting oxygen will enhance oxygen delivery to tissues, especially those brain cells and then the cardiac muscle cells. We will elevate the head of the bed. However, if the patient is hypotensive, we have to be careful of this. Please take note. Ladies and gentlemen, again, please listen up, and then listen up one more time. We are going to be administering medications. We can administer the diphenhydramine hydrochloride, otherwise known as Benadryl. We can administer corticosteroids as ordered. This will inhibit the anti-inflammatory response. Administer bronchodilators as orders. This will ease the bronchoconstriction. We will anticipate the order for the stat dose of epinephrine. If the reaction is severe, this will counteract the anaphylactic shock. We can administer vasopressors as they are needed. This will constrict the blood vessels to increase the blood pressure. And we will stay with the patient and provide reassurance that this patient will be very anxious and very fearful. Please take note. Please, ladies and gentlemen, listen up, and listen up one more time. We will educate the patient regarding potential causes in the environment and ways to avoid exposure to the allergen. We will educate the patient regarding the signs and symptoms of the initial reaction, such as the rash and the itching. We will educate the patient and the family on the use of the EpiPen. And then we can also advise the patient to obtain a medic alert bracelet or a pendant and ensure that healthcare professionals are aware of any potential allergies. So, how do I know that I've done a good job taking care of this patient with a type 1 hypersensitivity reaction? The well-managed patient will be free of symptoms of the allergic reaction and has a normal oxygen level. With the removal of the offending agent and appropriate treatment of the allergic reaction with diphenhydramine hydrochloride, again, otherwise known as Benadryl, steroids, bronchodilators, and epinephrine if necessary, there will be no further evidence of a rash, itching, or difficulty breathing. The patient is discharged when respiratory and cardiovascular assessment criteria has returned to their baseline. And then after a severe allergic reaction for which the cause is not known, a trigger should be identified if that is possible. So, type 2 hypersensitivity reactions. Type 2 antibody-mediated hypersensitivity reactions will include 3 subtypes: complement and antibody-mediated, complement and antibody receptor, and antibody-mediated cellular dysfunction. So, one example of a type 2 hypersensitivity reaction that will cause cell destruction is erythroblastosis fetalis, which is due to RH sensitization. RH sensitization occurs in approximately 1 in 1,000 births due to RH negative women. So, an example of a type 2 hypersensitivity that will cause inflammation is Goodpasture's syndrome. And this is when the immune system mistakenly makes antibodies that will attack the lungs and the kidneys. The syndrome is most common between the ages of 18 and 30. And again, it can show itself between the ages of 50 and 65. It is more common in males. An example of type 2 hypersensitivity that will cause cell dysfunction is myasthenia gravis. This disease can occur at any age, most common in females 18 to 25 years of age and males 60 to 80 years of age. Pathophysiology for each of the three subtypes of type 2 hypersensitivity has a basic component of complement and antibody-mediated cell involvement. Complement and antibody-mediated cell destruction hypersensitivity reaction is cytotoxic and antibody-dependent. Complement is a series of proteins that will distinguish the individual's own cells from foreign substances. So when this function is not working, the individual is susceptible to autoimmune diseases as a result of hypersensitivity reaction. The antibodies involved in this hypersensitivity reaction are immunoglobulin M, otherwise known as IgM, and immunoglobulin G, otherwise known as IgG. So in subtype 1, the targeting of cells for deletion by antibodies is mediated by the complement system or by antibody-dependent cell-mediated cytotoxicity. With ADCC, cells are coated with IgG, are killed by various effector cells that will bind to their target by the receptors for IgG. Cell lysis will result without phagocytosis. So examples of subtype 1 are blood transfusion reactions that will occur when incompatible blood is transfused, hemolytic disease of the newborn due to blood type ABO or Rh incompatibility, and then certain medication reactions. So ladies and gentlemen, listen up, and then listen up one more time. A person with type A blood has A antigens and anti-B antibodies. A person with type B blood and B antigens and anti-A antibodies. A person with AB blood has both A and B antigens and no antibodies. A person with type O has no antigens and both anti-A and anti-B antibodies. Ladies and gentlemen, please take note. So, complement and antibody-mediated inflammation causes inflammation rather than destruction. An example of this type is Goodpasture's syndrome, and that is an autoimmune disease that is triggered when the patient's immune system will attack the Goodpasture's antigen, and this is an antigen in the glomerular basement membrane. So this is also known as anti-glomerular basement antibody disease. These antibodies combine with tissue antigen to activate complement. This causes deposits of IgG to form along the basement membranes of the lungs or the kidneys. So this disease is characterized by glomerulonephritis and hemorrhaging of the lungs and results in damage to the kidneys and the lungs. This is a rapidly progressive disorder. Antibody-mediated cellular dysfunction is a hypersensitivity reaction where the antibodies bind to cell surface receptors. So an example of this is myasthenia gravis. In myasthenia gravis, autoantibodies to acetylcholine receptors on the neuromuscular end plates are formed. The autoantibodies either block the action of acetylcholine or mediate the destruction of the receptor. This will lead to decreased neuromuscular function and therefore weakness. Treatment of type 2 reactions requires removal of the medication or blood product that is causing the reaction. Plasmapheresis involves filtering the plasma to remove substances that precipitated the cytotoxic reaction. So blood will be removed via a catheter, RBCs, and then the plasma will be separated and the RBCs will be returned to the patient. Goodpasture syndrome is treated with corticosteroids and immunosuppressive medications in addition to this plasmapheresis. Some patients will require IVIG and that is a solution made from human plasma containing mostly IgG antibodies to maintain antibody protection. So, depending on the amount of renal involvement, dialysis may be necessary, and then renal transplantation may be an option for some patients. So, complications of a type 2 hypersensitivity reaction. Complications such as renal failure or hemolytic reaction may be life-threatening. Lung damage, occurring as rapidly as the renal damage, may cause severe impairment of oxygenation requiring artificial ventilation. This patient may be anemic because of loss of blood through lung hemorrhaging over a long period. Medication reactions causing hemolytic reactions that cause cell lysis can produce transient anemia, leukopenia, or thrombocytopenia. Type 3 hypersensitivity reactions are immune complex mediated reactions. Like type 1 hypersensitivity reactions, there are two categories of type 3 reactions, systemic and local immune complex reactions. So examples of systemic immune complex reactions are systemic lupus erythematosus, otherwise known as SLE, rheumatoid arthritis, and then serum sickness. Systemic lupus erythematosus may be caused by genetic, environmental, or unknown factors. Systemic lupus erythematosus is more common in females than males, which is similar to other autoimmune diseases. And then rheumatoid arthritis will affect women 2.5 times more often than men. A type 3 hypersensitivity reaction involves the formation of an antigen autobody immune complex. Immunoglobulin G is the immunoglobulin that is involved. Manifestations of rheumatoid arthritis are caused by the immune complexes that are lodged in joint spaces. Systemic lupus erythematosus produces antibodies against virtually any organ or tissue in the body. Serum sickness is an immune system reaction to a certain kind of medication, more commonly penicillin and then other antibiotics or injected proteins that are used to treat immune conditions. It will usually develop within 7 to 12 days after the initial exposure, but sometimes can take as long as 3 weeks. If the patient is exposed to the substance a second time, serum sickness tends to develop faster within 1 to 4 days, and a very small amount may cause an intense response. Serum sickness is less common currently because vaccines are made with human proteins rather than being animal-based. So clinical manifestations will include fever, arthralgia, lymphadenopathy, which we call swollen lymph nodes, and then malaise. Polyarthritis, which is arthritis in multiple joints. Nephritis, this is inflammation of the nephrons in the kidney. Urticaria is a fancy name for hives. A patchy or a generalized rash. Extensive edema involving the face, again, we call that angioedema, neck, and joints. So, Arthus reaction is a localized vasculitis due to the deposit of immune complexes in dermal vessels after intradermal or subcutaneous injections, typically a vaccine. So within 4 to 10 hours, a red raised lesion will develop at the site of the injection. So, management of type 3 hypersensitivity reaction. Removal of the offending agent is the first treatment. Symptom management for systemic immune complex reaction will include aspirin for joint pain and antihistamines for the pruritus. For the severe reactions, epinephrine or systemic corticosteroids may be utilized. Type 4 hypersensitivity reactions. Type 4 is a delayed type hypersensitivity. Examples are poison ivy, command 2 test for tuberculosis, and then a latex allergy. Some patients may experience a type 1 and a type 4 reaction. Latex allergy may be an immediate, rapid type 1 hypersensitivity reaction or a type 4 delayed hypersensitivity reaction. Type 4 cell-mediated delayed type hypersensitivity is also known as cell-mediated immune memory response or antibody dependent. This type of hypersensitivity reaction is delayed and is regulated by T lymphocytes that are damaging to cells or cytotoxic. So this reaction usually occurs 24 to 72 hours after exposure to the antigen. Sensitized T lymphocytes are the cells that will attack the antigens and release cytokines and thus mediate the reaction. In the delayed hypersensitivity reaction, it will take 24 to 48 hours for a response to occur. Clinical manifestations of a local reaction typical of a positive TB test will include a wheal and a flare reaction. Clinical manifestations of a latex allergy may range from local contact dermatitis, rhinitis, and conjunctivitis to pharyngeal edema, and then a systemic severe response. So, as in other hypersensitivity reactions, treatment will be based on prevention, such as avoiding the trigger. If exposure does occur, antihistamines may help with a less severe reaction. Skin creams containing steroids help with contact dermatitis. More severe reactions that occur with a repeated exposure may require a trip to the hospital to receive oxygen, epinephrine, and IV corticosteroids to reduce the inflammatory response. So, some nursing management of a type 4 hypersensitivity, we will assess because we are nurses. So, the clinical manifestations seen with a type 4 hypersensitivity reaction are due to the tissue damage that is caused by the inflammatory response. And these mild reactions will include a localized skin reaction, conjunctivitis, and then rhinitis. More severe reactions can include severe respiratory distress related to pharyngeal edema and then anaphylactic shock. So, some nursing diagnoses for a type 4 hypersensitivity reaction: risk for localized tissue damage related to hypersensitivity reaction secondary to the trigger, risk for impaired oxygenation related to pharyngeal edema secondary to the hypersensitivity reaction. So, some nursing interventions for a type 4 hypersensitivity reaction we will assess because we are nurses. So, we will assess vital signs. A severe allergic reaction can produce clinical manifestations of anaphylaxis, such as respiratory distress with decreased oxygenation, hypotension, and tachycardia. We can assess the skin. Mild reactions may include rashes, and then we can assess for a previous history of allergies. A secondary exposure to a trigger after an allergic reaction can cause a more severe anaphylactic response. So, a nursing action for a type 4 hypersensitivity reaction would be to administer medications as ordered. Steroid skin creams and or IV corticosteroids may be necessary to decrease inflammation. IM epinephrine may be necessary to relieve respiratory distress and increase blood pressure in a severe reaction. So, patient education for a type 4 hypersensitivity reaction: educate the patient to avoid the exposure to the trigger. Instruct the patient to wear a medic alert bracelet and inform healthcare providers of allergies. It is essential that the patient identify allergies to avoid exposure as much as possible and aid in the response should a reaction occur when the patient is unable to articulate a problem. Instruct the patient on the use and the necessity of an EpiPen. The EpiPen will deliver a small dose of epinephrine to counteract the allergic response, decreasing respiratory distress and then increasing the blood pressure. So how do I know that I've done a good job taking care of this patient with a type 4 hypersensitivity reaction? The patient will avoid the complications that are related to hypersensitivity reactions by maintaining a heightened awareness of their triggers and by carrying an EpiPen and wearing a medic alert bracelet. They can avoid an inadvertent exposure to a trigger. Again, ladies and gentlemen, thank you for your time and attention. I hope this helps. And as always, please reach out with any questions, comments, concerns, or if you think I can help.